So if patients have, if PARP is working too hard, I think is a good way to think about it, and we can identify, we know that patients that have a BRCA1 or BRCA2 mutation, that's part of that pathway, then we can give the PARP inhibitor to kind of turn it off, so to speak, is I think a good way to think about it. We know there are some tumors in breast and ovarian cancer especially that that are impacted by PARP, and so if that tumor is has a mutation in the BRCA1 or the BRCA2, that would guide our tailor or make for a personalized treatment with a PARP inhibitor agent. It is really changing what we do in the genetic world, because we used to not think about offering genetic testing to someone if, say, they were 65 years old with metastatic breast cancer. That might not have been a reason to necessarily offer germline genetic testing, because that really wouldn't look like enough history. But it would guide and change their treatment. So we are now seeing some families, individuals who do genetic testing, and they find out that they do carry a BRCA1 or BRCA2, and that opens up this whole new kind of set of challenges, in that now their first-degree relatives would be at risk, so their daughters and sons could be at risk, or their siblings could be at risk. So this test that we pick that's going to guide treatment has this very far-reaching effect for these families. We know that that there are a number of genetic mutations that probably are part of that we need to pay more attention to, and that they probably are affected by PARP, because the PALB2 and the ATM, they are up and down regulators of the BRCA1 and BRCA2. We don't understand them as those genes as well. We don't understand them as well from a hereditary point of view either. We know, well, the risk for these other cancers may be associated with this, but we don't fully understand that. We also don't fully understand how common some of those are. Testing for the ATM, PALB2, some of those genes has been available probably routinely for about 3.5, 4 years. So it's not like the BRCA1 and BRCA2 where we've been testing since the early 2000s. We know a lot more about the risk associated with carrying those genes, and we have a better idea of how common they really are in the general population. Until we do more testing overall, we're not going to know how common these are, but they are definitely part of the pathway. And so when we do genetic testing, we're not usually just testing for just the BRCA1 and BRCA2, but we're testing for multiple things. With our patients, I think one of the things that oncology nurses need to be especially aware of, and physicians and everyone that orders it, is the concept that we order this and we're thinking about the patient's treatment in the moment that we do it. And I think patients need a little counseling even at that point, that says that if we find something, this is not going to be just about you anymore, that this is going to be about many of your other family members. It is devastating for individuals to learn that they have genetic risk for developing cancer, and a lot of times when this is presented, they're like, well, we'll do this testing because it's going to help us to pick a therapy, and that is absolutely correct, but they don't understand, patients and families don't always understand that they could also be learning something that they maybe weren't prepared for. So anticipatory guidance as we manage these families, and realizing that it is devastating when they learn that, and that if that's been ordered and then we understand that the patient has it, that getting the rest of the family to the care they need is critical.